I was never a big milk drinker as a child, so I don't know what would happen if I sat down and drank a glass of milk, because I've never done that.
Some people, we find, may tolerate the first cup of coffee, but the second cup, the first sip of the second cup of coffee will sometimes trigger a reaction. So the most important thing for a person to understand is that there is a treatment out there for everybody. It's simply a matter of trying different treatments until you come up with the magic combination that works for you.
I agree. I think that as much as you can read, I mean, when I was first diagnosed with IBS, like everyone, I jumped on the internet. What could I pull out? What books could I read? And everything I read told me the opposite. Eat fiber, don't eat fiber. Eat white flour, don't eat white flour. Eat vegetables, only eat cooked vegetables. So I always heard the opposite. So that was when I sort of said, I need to take control.
And it's something that both of you mentioned about taking control. We do have to take a break. Coming up, the brain-gut connection. Please stay with us. Welcome back. Well, we're going to talk now about diagnosing and treating IBS. And I'm just wondering, if you were to take a camera inside Suzanne or Jeff's body, how would it differ from my body?
Well, assuming that everyone's healthy and normal, the image would be the same. You wouldn't see any difference visually. What we're looking at is a diagnostic dilemma. We're trying to establish a diagnosis by doing the minimum amount of tests. And over the years, it was a process of elimination. But currently, the diagnosis is now a positive one. We're trying to establish irritable bowel syndrome on criteria that are presented to us. And these criteria have been nicely classified for us, but they're basically defined as 3 months in the past year of abdominal pain, a change in bowel habit, be it constipation, diarrhea, and abdominal bloating. If you have that without any red signals of disease, namely weight loss, so no weight loss, no visible blood in the stool, no nausea, no vomiting, nothing on examination that would alarm the physician, then you're making a positive diagnosis based on the history, on the presentation of pain, change in bowel habit, and no other worrisome features.
So there's no test that you can do. There's no blood test. There's no physical exam that will tell you you definitely have IBS.
Unfortunately not. There is no surrogate marker that will tell the physician or the individual that they have IBS. It's based on the presentation of signs and symptoms, or actually the presentation of symptoms, lack of signs of disease, and normal investigations. It's advised that anyone under 50 who presents with irritable bowel should have a complete blood count first. That tests the hemoglobin, white count, and so on. That should suffice. In the diarrhea-dominant IBS, you might want to do a stool study for pathogens, bacteria, etc. But that's about it. Anyone over the age of 50 should have a colonoscopy.
One of the concerns being that IBS can be mistaken for other problems.
For instance, inflammatory bowel disease, Crohn's, ulcerative colitis, which can be more serious. But again, we always recommend that a patient not diagnose themselves. If they are not feeling well and they feel they have these common underlying symptoms, that they speak with their physician and let the physician who has experience with doing the diagnosis make that diagnosis.
Absolutely. In fact, the diarrhea-dominant IBS has a spectrum of potential illnesses that shouldn't be overlooked. Something is like celiac disease and inflammatory bowel disease and so on. But generally, they're manifest by some weight loss, fevers, sweats. I mean, there are other systemic complaints associated with that. Irritable bowel patients are healthy but distressed because of their bowel.
So once you get the IBS diagnosis, the availability for drug therapies, we touched on a little bit earlier, but what is out there for, if we start with Suzanne, because you've had really amazing success with the drug that you're taking.
Yeah, currently I'm on Zelnorm, and I've been on that for just over 3 months, and I've had great success with it. I'm living again, my life is back to normal, and I've stopped obsessing.
So just 3 months it's taken for Zelnorm does what?
Well, before we jump to that, I just want to reiterate the importance of balance here, the balance of diet therapy, the balance of psychological issues that may be influencing irritable bowel. And once you've addressed that, then you have to move into the spectrum of drug therapy, be it conventional or unconventional. A lot of our our viewers and our patients are out there looking at probiotics, which can have a very important role in irritable bowel syndrome.
Probiotics being?
Good bacteria, sort of pushing out the bad bacteria of the gut, generating good health within the
Is that
the
like
colon.
acidophilus and those kind of things?
Yes, lactobacillus, there's some Peptostreptococcus, bifidobacter. There's some very
You're
nice
speaking
products.
a different language to a lot of people who haven't been into a health store lately.
Well, you'd be surprised how many people know this. Yogurt is a very good one.
But you want to get active bacteria yogurt or whatever it's called,
you
right?
have to have live bacteria, and there's some products that are coming out like that. But that's just an example. Then we move into the conventional drug therapy, and I'll put bran actually into drug therapy and fiber supplements as drug therapy. But then that's where you break off and look at the constipation-dominant IBS and the diarrhea-dominant IBS, and you have a spectrum of drugs for both of those.
But what specifically do they do? If your body isn't any different on the inside, what is this drug doing that's making Suzanne's life worth living again to her?
So as we've evolved our understanding of the biology of irritable bowel, we recognize there is a hormone imbalance, a neurotransmitter or a chemical in the bowel that seems to be out of kilter. It seems to be imbalanced, and this chemical is serotonin.
Which we normally associate with serotonin in the brain, and there not being enough of it being depression.
Exactly. In fact, serotonin is throughout the body. There is CNS, central nervous system serotonin, and there's peripheral nervous system serotonin, or enteric nervous system. That's the brain of the gut. And that's very dependent on serotonin transmission. So serotonin seems to be the darling chemical in the bowel right now.
So are you essentially taking an antidepressant for your stomach?
Well, you're taking a modulating drug. You could say it's an anti-serotonin or pro-serotonin. Now let's come back to that. So talk about balance again. So for irritable bowel, if it's a diarrhea-dominant irritable bowel, there tends to be too much serotonin. If it's a constipation-dominant irritable bowel, there seems to be either a lack of serotonin or a lack of response to serotonin by receptors in the gut. So what we're doing with drug therapy is trying to balance this imbalance. In other words, giving a serotonin blocker to the diarrhea-dominant patient and a serotonin stimulator to the constipation-dominant patient.
Okay, I have to stop you right there. We do have to take a break, but we will have more on drugs in just a moment as well. What else has to be done to control irritable bowel syndrome other than just drug therapy? Please stay with us.